Thank you so much, ma'am. Good morning, everyone present here. As you all know, CGR is a wonderful opportunity for exchange of knowledge. And today, on behalf of Department of Gastroenterology, myself, Dr. Karthik Balankhe, and Professor Prabhu will be discussing today's CGR topic, that is third space endoscopy and EUS guided advanced transluminal interventions, a case-based approach. So to begin with, what is exactly this third space? You all must be wondering. So GI lumen is the first space. Outside lumen, the blue color peritoneal cavity is the second. And within the wall of lumen is what is actually the third space. It is a potential space. And here is where we do the third space endoscopy. So we must acknowledge the pioneers of this third space. First, an experiment was done in the animal model by Dr. Pasiri Chaitar, and it was then done in a human where endoscopic monitoring was done for Achilles by Dr. Inouye. So there are multiple applications of this third space endoscopy, and it includes varied GI disorders. To name a few, achalasia cardia, where poem or per oral endoscopic myotomy is done. Its variation that is G poem is done for refractory gastroparesis, Z for Zenkers, D for epiphytic diverticulum, and including star and EFTR, which are used for subepithelial lesions depending on their layer of origin. Star being submucosal tunneling endoscopic resection, and EFTR being endoscopic full thickness resection. So, how exactly do we enter the third space? This can be seen in this animation where the GI wall can be shown, where the layer of mucosa, submucosa, and muscularis propria are visible. To enter the submucosa, we create a blood without a normal cylinder. We do submucosal dissection and release the muscularis propria. This is then dissected for a which is the most important step of the G poem. Now, submucosal tumors, as we have just seen, they can be dissected carefully and removed using the previously created incision without the need of any more incisions. Having done these procedures, the residual defect is eventually closed using clips. So what has made an access to this third space a reality is the development of high definition endoscopes, various knives and specific caps. Now to begin, the procedure of per oral endoscopic myotomy, which is a natural orifice transluminal endoscopic surgery, and it is used in patients with achalasia cardia. Achalasia cardia being a motility disorder because of the neurodegeneration of the mesenteric plexus involving failure of lower esophageal sphincter relaxation. For its diagnosis, we need endoscopy where there is dilated upper esophagus, tight lower esophageal sphincter, barium confirming bird beak appearance, and the gold standard being high resolution manometry. So to see a related case, we had a 38 male who had dysphagia since 3 years for both solids and liquids, regurgitation for 1 year, retrosternal chest pain for 1 year, significant weight loss with normal blood parameters and ECG X-rays. Further endoscopy revealing dilated esophagus and tight LES, barium confirming significant contrast retention, and HRM confirming the diagnosis of type 2 achalasia. The Eckhart score, which is a score used to grade the severity, was 9. It includes specific parameters. The highest score is 12. And in our patient, the score was 9, demanding the need for intervention. So what can we do? We have options that include laparoscopic Heller's myotomy. It is a surgical procedure. It has its own limitations and complications. Next being pneumatic dilatation, which can be done via endoscopy route. However, it has a recurrence rate of about 60% at 5 years, and its technical and clinical efficacy is lower. So we decided to go ahead with OM or per oral endoscopic myotomy in our patient. And the technique will be discussed further by Professor Pravir Rai.
So the first step in doing a third space endoscopic procedure, especially POEM, that is peroral endoscopic myotomy, is the injection. So what we inject is a combination of methylene blue and saline. As you can see, we are creating a bleb here. And once the bleb is created, you have this mucosa separating from the submucosa. And so this is the bleb that has been created. After the bleb, creation of bleb, the next step is doing an incision. And as you will see here, so this incision is done with the knives that we use. In this case, we are using a hybrid knife. So this incision is around 1.5 to 2 centimeters. This incision should allow the endoscope to enter into this submucosal space. And the methylene blue primarily stains this submucosa so that you are able to differentiate it from the muscle. So after you have done the incision, you undermine the edges of the incision, and this is to ensure that your scope goes in easily. So this step is the undermining of the edges of the incision that we have made. And once the undermining is sufficient, then we pass in the scope. As you can see, we have entered into the submucosal space. This is the submucosa, and on this side will the mucosa. Below you have the muscle layer. Once that is done, you have made a tunnel. You can see this tunnel, and we extend this tunnel around 3 centimeters below the G junction. You have this muscle exposed. Now, the muscles in esophagus are primarily the circular muscle and the longitudinal muscle. You can see we are incising the circular muscle, and as soon as you incise the circular muscle, you can see the longitudinal muscle below. So there is a debate whether you should do a complete, that is both esophageal both circular and longitudinal, or either only one of it. So what we usually follow is that at the G junction, we do a complete myotomy, that is both esophageal, both circular as well as the longitudinal. And this myotomy usually extends 2 centimeters into the gastric side. And this is very important to ensure that the patient does not have recurrence. As you can see, the whole muscle is exposed, and then you have cut, and then you have the adventitia showing up. So after this, the last step is the closure of the incision that you have created in the mucosa. So this is very important just to ensure that there is no perforation. So cutting the muscle here is not a perforation, but if you don't close the mucosa appropriately, you will have a perforation. So to continue further, Karthik.
So having done this procedure 3 years back, the patient is under follow-up and he's doing perfectly fine. Now coming to a few key aspects of POEM procedure, the clinical success defined by Eckhart score of less than or equal to 3 is more than 88% at 3 years and more than 80% at 5 years. Adverse events are usually mild to moderate, the severe being to the percent of less than 1. Insufflation related events are usually again mild, and they are seen because during myotomy, we tend to even reach the submucosa, and the gas that is used for insufflation is CO2. Hence, it may even leak to the surrounding regions. However, they are usually mild and not a major concern. They can be even identified during the procedure under fluoroscopy, and few of them are capnothorax, capnoperitoneum, and capnopericardium. Now, again, a few important side effects. For example, gastroesophageal reflux disease after POEM. So this was studied by a multi-center retrospective Japanese study involving about 3,000 patients. LA grade C or worse esophagitis, which is the severe form of esophagitis, is seen in about 7.5% of patients, and the patients who were symptomatic were just 16%. Hence, again, this is not a major thing to worry about. Now, reflux symptoms in these patients can be because of reflux per se, or even because of non-reflux esophageal acidification because of the food stasis, and even hypersensitivity reaction to the chemical or mechanical stimuli. To confirm, we need 24-hour pH metry. And as was seen in this study, the symptoms were well controlled with PPI, and its incidence decreased over time. Now, there was a publication from our center itself regarding the randomized non-inferiority trial studying the short versus the long esophageal myotomy, short being less than 5 centimeter and long being 6 to 10 centimeter. The baseline characteristics of our patients were comparable in both the arms, Eckhart score being 7 to 8. Type 2 achilles patients were predominantly seen in both the arms. IRP was elevated in both the arms, being 30 plus, and time the almost 6 to 7 centimeters hyperbarium column in 5 minutes. Coming to the perioperative outcomes, again, both the arm showed comparable outcomes, except the length of myotomy, which is expected to be short in the short myotomy group, and operative times as well being lesser in the short myotomy group. Now, comparing the clinical success, what was found is that the ECART score at 1, 3, 6, and 12 months was absolutely comparable in both the arms, being 0 to 1. Even clinical success, as you can see, in both the arms was above 96%, and IRP reduced from more than 30 to just 12 or 13 in both the arms, and hence there was no significant success change as seen in the p-value. Now, comparing POEM with other modalities, especially pneumatic dilation, there was an RCT that was published in 2019 involving 133 patients. Now, what was seen at follow-up of 2 years is that in the group of POEM, the treatment success was 92% as compared to just 54% in the pneumatic dilation group. Hence, POEM was considered way superior to pneumatic dilation. Now, comparing POEM with surgical myotomy in patients with achalasia, another RCT was published in 2019. Primary point being assessment of clinical success at 2 years, comparing the ECART score. In that, you can see POEM had a clinical success rate of 83% as compared to 81.7 of laparoscopic Heller's myotomy. Reflux symptoms, however, were higher in the POEM group, that is 44% as compared to 29 in the surgical group. Hence, the conclusion here was POEM was non-inferior to Heller's myotomy plus DOS fundoplication. However, surgery has its own limitations, and hence we decided to opt for POEM in our patient. Now, from POEM to its modification, which is G-POEM or a gastric POEM, which is done in patients with gastroparesis. In brief, we all know gastroparesis is symptomatic delayed gastric emptying of solid food, and there is no fixed mechanical gastric outlet obstruction. The potential etiologies being endocrine disorders like diabetes, post-surgical, like vagal denervation procedures, medications, and idiopathic. The idiopathic group is the most common etiology, and we see the patient to have medically refractory gastroparesis when we have an objective confirmation and symptoms persist despite dietary and use of drugs, that is metoclopramide. So what are the treatment options that are available for refractory gastroparesis? There is an option of botulinum toxin injection. However, it has a high recurrence rate of about 60% at 5 years. Its efficacy is around 40 to 50%. Percutaneous FJ is again surgical procedure with its own complications. Gastric electrical stimulation is not available everywhere and is costly. Partial gastrectomy is again a surgical procedure. Now, laparoscopic pyloroplasty has comparable clinical success rates as that of POEM. However, it being again the surgery with its invasive and complications, it is not always preferred. And the last case on block is the G-POEM. So we have a case related to that. We had 27 female who had recurrent nausea, postprandial vomiting for 2.5 years with early satiety, bloating, not relieved with medical therapy, with significant weight loss, with normal hemogram, LFT, RFT, glucose values, upper GI endoscopy revealing no fixed gastric outlet obstruction, CT scan again showing no abnormality, and the radionuclide gastric emptying scan confirming the delayed gastric emptying, that is the gastric emptying was 56% at 4 hours when tested with solid food, normal being at least 90%. So having confirmed gastroparesis, we applied the GCSI, which is the gastroparesis cardinal symptom index, which was 4 in our patient. The score ranges from 0 to 5, and recommendation is to offer POEM if the GCSI score is more than 2. So we went ahead with the POEM procedure. The basic steps are same, and it will be discussed ahead by Professor Praveer Rai.
So I think unlike POEM, which is almost established procedure, this G-POEM, again, not too many cases have been done till date, and we still need large studies for this. So if you see this G-POEM, it's the technique is almost similar. This is the stomach, this is the pylorus. So you begin the injection around 5 centimeters proximal, and then once you have created a bleb, again, the steps are the same. You incise this, again, a incision sufficient to let the scope go in. And then as you incise, so here, as the surgeons also have bleed, now we're also seeing bleed in this particular case. So once bleed is there, you need to control that bleed with the quad grasper. So, and then you enter into the submucosal space. So as you can see there, bleed is happening. So now we have devices like quad grasper, which controls the bleed adequately. So this is very helpful in all these procedures. And then you enter into the submucosa, keep on making the tunnel reaching up to the pyloric rim, up to the pylorus. And once the pyloric ring is identified, you go ahead and incise the pyloric ring. So that is pyloric myotomy. And as you can see here, it's very, very important to be cautious that you can see this pyloric ring here and you incise this. And it's very important here that not to injure the duodenum ahead. So once you have done this myotomy of the pyloric ring, the pylorus, again, the space of the pylorus goes. So you can see the myotomy here. And then as the last step, you need adequate closure of the incision that you have made. As you can see, we are using a lot of clips here. That sometimes it does happen that it's difficult to close the incision, and then you may need a lot of clips. Yeah.
So having done this procedure successfully, the patient is under our follow-up since last 2 years and is asymptomatic. To have a brief study about this poem, which was seen in a systematic review and meta-analysis published last year, where 15 studies were included and about 1,000 patients were studied. At a mean follow-up of 21 months, what you can see is the full clinical success rate was in the range of 60 to 70% in all the etiologies, that is in the post-surgical conditions, in idiopathic, as well as in patients having diabetes. And there was significant improvement in the GCSI scores. Hence, G-PROM is effective and safe for treating refractory gastroparesis, irrespective of the etiology, with significant improvements in clinical success rates and the GCSI scores. Now, moving ahead, changing our scope from a conventional endoscope to a EOS guided or a scope that has endoscopic ultrasound transducer at its tip, so that we can now study the EOS guided advanced transluminal endoscopic interventions. The two important interventions that we'll be studying now include EOS guided gastroenterostomy and EOS guided gallbladder drainage. To begin our discussion with the first case, we had a female who had symptomatic gallstone disease. She underwent cholecystectomy elsewhere. The biopsy report from the GB specimen later revealed adenocarcinoma. She then presented to us with jaundice, abdominal pain, and weight loss. We suspected biliary obstruction due to residual carcinoma of gallbladder. Investigations revealed biliary radical dilatation, and MRCP confirmed the block to be at mid-common bile duct level. Also, CT scan revealed paraortic lymph nodes, which were sampled, and FNAC was positive for adenocarcinoma, thus confirming the diagnosis of metastatic carcinoma of gallbladder with extrahepatic biliary obstruction at the level of mid-CBD. So further course, the patient's biliary drainage was done using ERCP with transpapillary uncovered biliary SEMS, which is self-expanding metal stent placement. It resulted in reduction in jaundice, and patient was initiated with chemotherapy. However, patient again presented 2 months later with postprandial vomiting. CT of the abdomen revealed the mass 4 by 2 centimeter in the GB fossa with duodenal infiltration. An upper GI endoscopy was done with revealed narrowing at the D1, D2 junction, and hence patient now had significant gastric outlet obstruction. Now, what are the management options that we have in general for gastric outlet obstruction? We can either subject the patient for surgical gastrojejunostomy or an endoscopic duodenal SEMS placement across the tumor growth, and the last being EOS guided gastroenterostomy. So every procedure has its own advantages and limitations. Regarding surgical gastroenterostomy, it provides symptomatic relief in more than 70% of patients with fewer reintervention needs, and it is the treatment of choice when patient's life expectancy is more than 3 months. However, usually these patients are frail with an advanced metastatic carcinoma, and the life expectancy is not always more than 3 months. Also, there are significant morbidity issues, post-op bilious and anastomotic leaks associated with the surgery. Another modality is placement of duodenal SEMS, which has similar efficacy to that of surgery, is less invasive, helps in providing rapid symptom relief and earlier initiation of chemotherapy. The main problem here is the increased need of reintervention due to the tumor ingrowth that occurs through this uncovered SEMS. And the latest addition is the EUS gastroenterostomy, which can be successfully done even in critically ill patients, especially those who are having low albumin. And these patients have a shorter hospital stay. This is a less invasive procedure than surgery. And its advantage being that it can bypass the tumor with prolonged stent patency. Problems, as we all know, that this uh, procedure needs special devices. As shown, the device on the top is a cautery enhanced lamps, and the device below is a double balloon. Now, this double balloon device is not yet available in India. There can be possible serious adverse events in this procedure as well. Now, what are the three techniques for EUS gastroenterostomy? First is the freehand or a direct technique where a direct puncture is made from stomach into the small bowel. The image B shows an assisted technique where balloon catheter or nasobiliary tube is used to access the small bowel, and the third being a E-pass technique where double balloon is used. Now, we at our center use a nasojejunal tube assisted gastroenterostomy, which will be discussed ahead.
Yeah. So the technique, since this double balloon is not available with us right now, it's not commercially available. So what we use is a nasojejunal assisted technique. So what is it? So if you see the normal bowel, if you puncture the normal bowel, it moves away. So this is the problem. So once you distend the bowel and then try to puncture, you will possibly be successful to puncture the bowel. So as you can see, the first step that we do is to place a nasojejunal tube across the site of the obstruction. So if there is a total obstruction, you obviously can't do this procedure with our technique. And then once you have past the nasojejunal tube, as you can see, this is the collapsed bowel that you're seeing from the stomach. And once you distend this with the nasojejunal tube, this is what you get. So this is a distended bowel, small bowel. Just have to be sure that it's small bowel and not a colonic loop. You apply Doppler because we are going to place a cautery enhanced stent, that is a cautery device loaded with a stent in place. This has gone in. Once it has gone in, we deploy the distal flange, pull this across the stomach wall, and then we deploy the proximal flange in the stomach. That you can see right now it is being deployed, and we instill the fluid that we use to instill the bowel, to distend the bowel, is saline along with methylene blue. And as soon as you deploy the stent, you can see blue colored fluid coming out. This convinces you that you are in the small bowel only. You will see this blue colored fluid coming out. And once everything is set, the whole procedure takes just around 5 minutes to deploy this stent. However, you need to be sure that the site of the puncture is correct. And then you can go ahead and try to dilate this stent as well. Though the stent opens up within a period of 24 hours, as you can see, this has got flares at the two ends, which are around 27-28 millimeter flare. The diameter of the stent that we use is a 20 millimeter diameter. So this is the whole procedure. So you don't need to dilate at the very time when you do the procedure. It usually opens up on its own.
Now, during follow-up, the gastric outlet obstruction of this patient was eventually really normal diet was resumed and palliative chemotherapy was restarted. And also we have a publication on the same where nasojejunal tube assisted EUS guided gastrojejunostomy was done in malignant gastric outlet obstruction, where 30 patients were studied in a retrospective study. The most common etiology in our study was carcinoma of gallbladder. Now, as you can see in the table on the right, the clinical success was in 29% and technical in all 30% patients. Median follow-up in 210 patients. and stent misdeployment was seen in just one patient. Now, comparing EUS gastroenterostomy with other techniques, that is duodenal stenting, and multicenter RCT was published last year in Lancet Journal, where 48 patients were seen in USGE and 49 in the duodenal stenting arm. The primary outcome that was studied here was the need for re-intervention within the first 6 months. And here, as you can see, EUSGE had just 4% need of re-intervention as compared to 29% in the duodenal stenting arm, which was statistically significant. Other parameters in this study did not differ statistically, as we can see, especially technical and clinical success and the adverse events. And hence, EUSGE reduces reintervention, improves patency, results in better patient-reported eating habits. And the conclusion of this study was that EUSGE should be preferred over duodenal SEMS placement. Another retrospective study involving about 430 patients compared EUSG in one arm, duodenal stenting in the second, and surgical G in the third. Now comparing one by one, as you can see, where EUSG was compared with duodenal stenting, the clinical success was superior in the EUSG procedure. Length of hospital stay, need of intervention, and adverse events was statistically lower. Also, when the EUSG was compared with the surgical G, again, clinical success was higher in the EUSG arm, and we can also see the need for re-intervention and adverse effect events being lower in the EUS arm. So to summarize, we can see the efficacy-wise, every procedure, that is duodenal stenting, surgical, and EUS guided gastroenterostomy, have a high efficacy. Duodenal stenting does not bypass the tumor, while the other to do bypass. And shorter time to OP feeding and shorter hospital stay is seen in duodenal as well as the EUS arms, but not in the surgical group, because it is followed by treatment with relatively high complication rates and is contraindicated in critically ill patients. EUS procedure demands expertise, and there is a limited long-term efficacy with duodenal stenting due to tumor ingrowth. So this is what approach we followed at our center. When we have a patient with a malignant gastric outlet obstruction and expected survival less than 3 months with a poor performance status, then we go ahead with duodenal stenting. In the same category, if the performance status is good, then we opt for EUSGE. If the expected survival is more than 3 months with a good performance status, then again EUSGE is preferred, and surgical G is opted when there is a contraindication to EUS procedures. Now, coming to another interesting endoscopic drainage procedure, which is EUS guided gallbladder drainage. In general, you all must be knowing there are 3 options available to drain the gallbladder. First is the percutaneous route, where under radiological guidance, we puncture the gallbladder and drain it. Second is using ERCP, where we place a stent from the ampulla through the CBD cystic duct into the gallbladder lumen. And third, and the latest one, being EUS guided gallbladder drainage. Now, when exactly is this EUS guided gallbladder drainage done? So it is done for patients who are drainage in high risk surgical cases and having acute cholecystitis, and for drainage of malignant biliary obstruction in patients who have failed ERCP and failed EUS guided CBD drainage. So we have a related case with us where 30-year male presented with jaundice, abdominal pain, fever, ultrasound revealed dilated common bile duct, side view endoscopy showing a large ulcerated ampulla with biopsy confirmation of adenocarcinoma, CT scan revealing a likely resectable status. So this was a likely resectable periampulary carcinoma, biopsy proven, for which ERCP and CBD stenting was done since the patient was in cholangitis. Staging laparoscopy done later showed para-aortic lymph nodes and intrafrozen section, again confirmed adenocarcinoma, thus making it a metastatic periampulary carcinoma, and chemotherapy was initiated since biliary drainage was already achieved. However, after 2 months, the patient again presented to us with jaundice and postprandial vomiting. Blood test revealing raised total leukocyte count with raised bilirubin of 15, raised alkaline phosphatase, ultrasound abdomen showing dilated CBD IHBRD in both the lobes with no pneumobiliary stent in situ and a distended gallbladder with acute cholecystitis. Endoscopy again confirming gastric outlet obstruction at the level of D1 and D2 junction, hence making the diagnosis of stent block with cholangitis in this patient with gastric outlet obstruction and acute cholecystitis. So how did we manage this patient? We first attempted an EUS-guided choledochoduodenostomy. It basically involves puncturing the common bile duct from the duodenum. However, this procedure was not successful as there was already a plastic stent within the CBD and hence the proper puncture could not be obtained, which can be seen in this illustration where the common bile duct has a black colored representative stent and it often hampers the insertion of metal stent from the duodenum into the CBD. So what next? You all can see there is a gallbladder which is in close approximation with the duodenum. Hence, our next plan was EUS-guided gallbladder drainage. And this technique will be now shown to you.
So I think for us, this is a very interesting procedure and quite rewarding as well, especially in the scenario that we were stuck in this patient. So if you see this in this image, we have our scope positioned somewhere in the antrum or in D1. So, and you can see a distended gallbladder. So normally the gallbladder is very near to the first portion of the duodenum compared to your antrum. So you can see we puncture with a, as you can see this first step, we have positioned this in D1. This is a long loop position. This you are seeing is a 19 gauge FNA needle. And with puncture into the gallbladder with a 19 gauge FNA needle, the next step is to pass a wire. So this is the wire that you can see going and looping into the gallbladder lumen. So you have, this is the fluoroscopic image. On the screen, we have a PIP, that is picture in picture. So the picture that we see on the screen is that of an EUS image. So this is the fluoroscopic image. And along with this, we do have on screen the EUS image as well. So after puncture, after you have punctured and passed a guide wire, the next step is to dilate this tract. So we dilate the tract, and this is the conventional technique that I'm discussing. So you can see this is the endoscopic image now. We have passed in a wire, and then we are passing a balloon over it. This is a small caliber balloon. This is a 4mm hurricane balloon that we are using in this particular case. And once you have achieved dilatation with a balloon, the next step is the deployment of the stent. So you can choose to place either a plastic or a metal stent. However, the stents that we use routinely in all these patients is a fully covered biflanged stent. So these stents, as I mentioned earlier, have a caliber of say around 15mm or 20mm. And the flanges that you have are large just to ensure that the stent does not migrate. So these are, the length of the stents again is around 2 centimeters that we use for gallbladder, or only 1 centimeter that we use for GJ, gastrojejunostomy, that was shown earlier. So as you can see here, this is a stent which is available in sizes 2 centimeter long or 3 centimeter long. You can see the wide flares here and the bile coming out as soon as you deploy the stent. So you can see here, this is again from the antrum. So as I mentioned, there is a debate whether you should be puncturing from the antrum or you should be puncturing from the duodenum. So the only difference that it makes is sometimes one side is a bit easier. From antrum, there is a risk that the food can go inside the stent and in the gallbladder. So that will lead to possibly more chances of obstruction of the stent a bit early in the course if you follow these patients. Vis-a-vis, if you deploy a stent across the duodenum into the gallbladder, that chance is less. However, the problem is, I think that surgeons, majority of these patients are inoperable. However, if these patients are offered surgery, which the literature we have, So surgeons have difficulty in closing the fistula between the duodenum and the gallbladder. However, the fistula which is there between the stomach and the gallbladder is easier for the surgeons to take care of when these patients undergo an interval cholecystectomy, if these are operable patients. So again, a similar video showing the conventional technique. So here we use a slightly different technique, that instead of the multiple steps, we pass again a cautery enhanced device not loaded with stent. So this is a 10 French cystotome. So after passing the 10 French cystotome, you don't need any additional device. So this is cheaper compared to the direct puncture, which we were discussing. So once you have punctured this, again, the next step is the same. You deploy the stent, as you can see in another patient. This is the stent that is being deployed. So this is again a case done in 2017. As you can see, we used to place a double pigtail stent across this metal stent just to ensure that the stent does not migrate. So the other technique is known as direct puncture technique. So this is the technique that we use now, because in 2017, this stent had just come out, was not available at that point of time. This is again a cautery enhanced device, as we showed in GJ, gastrojejunostomy. So here you just puncture with this cautery enhanced device, deploy the distal flange in the gallbladder, just ensure that you are well against the wall. And after you have done that, you just deploy the proximal flange. So as you will see, the proximal flange again will be deployed and the bile starts coming out immediately. So after you have done this procedure, it's very important that if you have stones here, you can simultaneously remove the stones from the gallbladder as well, either at the time of the procedure or maybe later on, depending upon the need. Slowly.
So on follow-up, the patient achieved biliary decompression, his leukocyte count decreased, bilirubin decreased, and 1 week later, the gastric outlet obstruction was tackled using anteroduodenal SEMS plate placement, as the patient's performance status was poor. Patient eventually resumed normal diet and chemotherapy was restarted. Now, the case that we showed you was actually the first report of endoscopic ultrasound guided cholecystogastrostomy with a Nagi stent for the palliation of jaundice, and this was again published from our center in 2014. Now, to have a comparative analysis on the three techniques, to begin with, on the percutaneous gallbladder drainage, so the patient selected have a poor surgical status. Now, this technique is widely available as it is done using radiology assistance, disadvantage being higher reintervention rates, recurrent cholecystitis that is seen in these patients. Next being ERCP, or a endoscopic transpapillary gallbladder drainage. Now, this can be done in those patients who have other coexistent indications for ERCP, for example, those who have choledocholithiasis along with cholelithiasis and say empyema, and who have future cholecystectomy candidates. Advantage being that this procedure is extremely safe in patients who have ascites and coagulopathy. Disadvantage being the low technical and clinical success rates, risk of pancreatitis since we are going through the ampulla, risk of stent migration, and it being contraindicated in patients who have gallbladder perforation. And lastly, EUS guided gallbladder drainage. So it can be done in patients who have failed ERCP or failed EUS guided choledochoduodenostomy. Advantage being least reintervention chances, and it is also useful in patients who have gastric outlet obstructions, as we have seen in our patient. Disadvantage being fistula closure requirement after cholecystectomy, occlusion with food, as we all just discussed, and it also being contraindicated in patients with gallbladder perforation. So, to summarize, unless the patient has gallbladder perforation, the preference should be given for endoscopic drainage over percutaneous gallbladder drainage. Now, regarding the outcomes with this procedure, that is EUS guided gallbladder drainage, the technical success rates are above 90%, reaching even 98.7%. Clinical success rates again from 90 to 98%. Adverse events rates being between 5 to 20%. including bleeding, recurrent cholecystitis, scent migration, and pneumoperitoneum. Now, after the resolution of cholecystitis, you must be wondering what to do with the SEMS that we place. So there are two options. First being, as discussed by sir, we can do a cholecystoscopy where we insert a thin scope into the lamps and remove the gallbladder stones at 4 to 6 week interval, and then exchange this with the lamps, that is exchange the lamps with the plastic stent. Option 2 being for those patients who are frail and who refuse surgery, in those we just leave the lamps as it is in situ. So to summarize, having seen both the third space and EUS guided procedures, POEM is a valid alternative to surgery in patients with achalasia cardia. GPOEM is an effective modality for the treatment of refractory gastroparesis of varied etiologies. EUSGE or gastroenterostomy is an alternative to surgery for malignant gastric outlet obstructions, and EUS guided gallbladder drainage being an excellent option for palliation of malignant jaundice and for high-risk surgical patients with acute cholecystitis. Thank you so much.